Everyone. Thank you so much for having me. I am a board certified dermatologist practicing in Southern California. I completed my residency in 2016. I actually trained on the East Coast in DC, but I'm from California. And just as a little FYI, if you hear anything crazy, that's probably my 3-year-old running around somewhere or trying to get my attention. So I'll try to avoid some of that, but just in case you hear that, I know sometimes when I'm doing meetings, he pops up somewhere. So today I just want to do a pretty quick lecture on some common skin conditions, just a couple, and I'm going to present them as clinical cases actually. And we'll keep it short, but I will ask for you guys to participate if possible, because I think it's better to be interactive, especially right now. So let me share my screen. We're gonna share this, just a second. I'm actually going to, I gotta put it in the slideshow mode. So you'll see me going through all of this because I'm not super great with this computer stuff, but now I'm just trying to get back to you guys. Okay, so can you guys see my screen?
Yes, we can.
Okay, good. Just making sure. So like I said, I'm going to go over some clinical case presentation. So I'm going to start out with this first case. Can someone just read this case out for me? I don't know, anyone would volunteer to do that?
I think I'll do it for you.
Okay.
A 28-year-old white man presents with a recent onset rash that involved the upper arms, back, and shoulders. The patient was otherwise healthy with no known allergies and no history of medication or chemical exposure.
Okay, good. So for the first part, this is just a presentation, as you read, of a young, pretty healthy male. So I just want to see if any of you guys can describe what you see in this photo. In dermatology, it's really important for us to actually describe the different rashes that we see, and we call this the morphology. The description is the morphology of the rash, and we use that to aid us in making our diagnosis. So I just wanted to see if any of you guys would be able or willing to give me a description of what you see.
So we have a lot of people saying white patches, white color spots, discoloration, uneven coloring, stuff like that, splotches.
Yep, that's great. So that's exactly what we do. We look at something, we want to take a look and describe exactly what we see, where we see it, and look for certain features. So in this case, we do see, as you guys mentioned, multiple small little hypopigmented, that means lighter skin color, round, slightly scaly patches. We can't tell in the photo that they're really scaly, but clinically in person, we would be able to tell that there's a little bit of a scale around these spots. So as I mentioned, it is important for us to describe these in order to guide our diagnosis. So in this particular case, this is Pityriasis versicolor or Tinea versicolor. This is a common skin condition that we see, especially during hot, humid months. It's caused by a yeast actually that normally lives on our skin, but overproduces during this time of the year in some of us. And versicolor, it's in the name because what you see are multiple colors. Usually we see this in young adults, but you can actually see it in older individuals or young children. Those are just more atypical presentations of the condition. So this is caused by a yeast, as I mentioned, called Malassezia fur specifically is the most common one that causes it. And what this does is that it can actually cause your melanosomes in your melanocytes. So these are the cells that make your skin color. They're found at the base of the epidermis. And so it can cause these cells to either make more color, and then that's when you would see like a darker pigment in these patches, or the yeast itself can produce a chemical that's actually azelaic acid, which is something that we commonly use to treat other conditions. But the yeast itself can naturally produce this chemical, and that actually causes the light spots. So how do we diagnose this? We usually diagnose this clinically, so just by looking at it. But of course, we always have tests that we can use to help us in making the diagnosis. So sometimes, you know, even if we see something clinically and it looks like it may be this, we may want to consider other conditions, because there are other skin conditions that can look similar to this. So some of the things that we can use to help us figure it out would be a Woods lamp, which is a special black light that we use to look at the skin. And in this particular condition, when you turn off the lights and turn on that Woods lamp, you would see a yellow-green fluorescence. We can also scrape some of the skin cells off of the skin and put it on a slide and look at it under a microscope. And this has a very, very classic appearance of the yeast. And we usually describe that as spaghetti and meatballs. And actually that comes up on exams a lot. It's a very classic presentation, and it's something that people love asking about. Of course, you can do a culture and actually grow it out, but a lot of times this culture tends to be negative. And then if you want to, you know, the last thing you would do, we try not to do skin biopsies unless we really have to. And sometimes we do to figure certain things out. But if you do a skin biopsy, it'll also have very specific features. So that's another way that this can be diagnosed. So this is what it looks like under the microscope if you do a KOH stain. So you can scrape off some of the superficial skin cells on top and then look at it under the microscope. And this is what it would show. As you can see, you have these little circles that we call the meatballs, and strands that look like spaghetti. So this is something that you'll probably just remember because you end up seeing it so many times, that, and it has like that very specific description that it helps you remember that. So in terms of treatment, a lot of times it's actually not that difficult to treat, and a lot of times it's not that uncomfortable to have. So like I said, during the hot humid months, you might get it. A lot of times we use shampoos to actually treat it or keep it at bay. So we can use like anti-dandruff shampoos for that. We typically tell patients to use the shampoo 2 to 3 times a week. Use it as a wash, leave it on for 5 minutes, and then rinse off. We do have other medications that we can use. Sometimes we can prescribe antifungal creams for patients to apply directly on the skin and use that for a couple of weeks. And at times, if you have a severe case or you can't get rid of it just with the topicals, then we do prescribe medication to get rid of it. And that's usually an antifungal to get rid of it. This is very common and it has a tendency to recur over and over. So you'll see a patient, they say they have this, and then you'll clear it out, but it tends to come back over and over, especially during those warmer months. The other important thing to note is that when this condition is actually active, that's when you see the little scale surrounding these spots. So a lot of times you'll see a patient back, say after 2 or 3 weeks of treatment, and they come back and they still think that the condition is active because they still see the discoloration or the spots. What we look for as dermatologists, we look for the scale. So if the scale is not present, then that means that that it's actually clear, but the discoloration takes months to resolve. So that's important, and that's something to warn patients about and let them know beforehand so that they're not overly concerned about the discoloration. Sometimes patients, when they see like dark spots or lighter spots on their skin, that can be very concerning, and they can become really stressed just thinking or focusing about that discoloration. So it's important to let them know that that will improve and it will get better. It's temporary, but it can take months to resolve. So I just wanted to show you different presentations of the condition because it looks different on different skin. So as you can tell, on lighter skin, you see more red and like scaliness on the lighter skin. And on darker skin, you're going to see lighter patches. So on the lighter skin, you'll notice a lot of pink, but as I mentioned, the darker skin, it's a lot of the light patches. So that's important to know that it looks different on different skin types. So this is the second presentation. Can someone read this one out?
Okay, I'll read it. A 12-year-old African-American boy.
I can do it.
Okay, thank you.
Thank you. A 12-year-old African-American boy presented with the recent onset rash that involved his trunk. The patient reported itching. He first noticed a single scaly itchy patch about 3 days ago, and then suddenly developed numerous.
That kind of hint at the diagnosis. And I'll mention that there's an arrow to one of the hints, and that's the first itchy patch that appeared 3 days before the rest of the rash. So that's a very important key point there. So if someone can actually describe what they see here.
Let me see what the comments are saying. Are those called pustules?
So these are not pustules. Pustules usually have pus inside. They're like little raised bumps with pus. So these are not pustules. The main one that we see, the larger one that we see, is a plaque because it's an elevated, raised rough patch. So that's a plaque.
We have a lot of people saying it looks like patches, dermatitis, maybe ringworm, bumps around the area. It's ashy. Let's see. So a raised rash, hyperpigmentation. Looks like it can be from insects. Someone said a Christmas tree pattern.
Good. I like that one. That's really good. Christmas tree pattern is really good. So here we go. So basically, you know, again, really important to describe what you see. And this is what we do clinically. Automatically, it's just in our head when we see it. But we describe the shape. So this is oval. We have a dark brown plaque with a collarette scale. Collarette scale is when you have a scale around the plaque. And then you have numerous satellite oval scaly smaller plaques in a Christmas tree distribution on the trunk. So the Christmas tree distribution is actually really important, and it's another hint to aid in the diagnosis. So when we say Christmas tree pattern, it's because when you look at the back, you see the rash is going down like this in this type of pattern. There's a very specific Christmas tree pattern that you see in this condition. Okay, so this is Pityriasis rosea. This is a viral rash that usually lasts 6 to 12 weeks. And as I mentioned, one of the key and hints to making this diagnosis was a description of a herald patch. The herald patch is the first initial patch that appears in this condition. And it's usually a larger patch on the trunk that precedes these smaller oval little patches that come out that then make that Christmas pattern distribution. In this condition, you can have anyone basically affected, anyone of any age, and males and female. A lot of times it's younger adults. Usually there's no sort of symptom associated with it. Sometimes some people report some itchiness, but typically most people do fine and they don't really have any issues with the condition, even though it looks, I think it's becomes scarier to them because they see something rapidly spreading on their body, and that becomes concerning. But most of the times people report like a history of maybe a mild respiratory infection, possibly some itching, but not a lot of discomfort associated with this. Sometimes they don't feel anything at all. The diagnosis, again, is made clinically, just as in the other case. You look at it, you just are so used to seeing these patterns over and over. And then the history, you ask, if you suspect this condition, you may want to ask your patient, did this start as a single patch? Did you first notice one patch? And usually they tell you, yeah, like a few days ago, I just had one and then it just spread to this. And so they usually tell you with their history. So this is associated with the reactivation of the herpes virus 6 and 7, which is normally the virus that can cause roseola in infants. So as we're older, as teenagers and young adults, we can see reactivation of this virus and it causes this condition. There are other viruses that can potentially trigger this condition, but that's more rare. And then this has a very classic appearance as the one that we saw and described, but sometimes you can have an atypical presentation of the rash. An atypical presentation would be when you see it in skin folds instead of the trunk, because usually it presents on the trunk, on the back, mostly on the back and on the chest, but sometimes you can have an atypical presentation that presents like in the groin or underarm area. And then in rare cases, you can have other culprits for causing this condition, and that can even be medications as the ones I have listed here, like non-steroidals like ibuprofen and different medications. So it's important for us to talk about the Herald patch, and you'll hear that term over and over again if you go into medicine, because it's very common. Again, there are certain things that are like key terms or keywords that you'll constantly hear and see on exams. And so this is one of them. And that's the single plaque that appears usually a few days before the rest of the rash, but it can be even 1 to 20 days before. A lot of times it can be different colors depending on the person's skin type. So as you see on somebody with darker skin, it may look brown. It can also look a little bit more like purple or gray on darker skin. And on lighter skin, the inflammation looks more pink or red. And you will see the trailing scale. That's the scale that you see on that outer portion of this plaque. And then you have the secondary rash, which is the rest of the rash, which presents, days after the initial one. And you normally would see that a lot on the chest or the back. And these are oval and they have like a little scale to them as well. And so the reason why we say this is a Christmas tree distribution is because it follows those the natural skin tension lines, which we call Langer lines. Our skin actually has normal tension lines that it has. And sometimes, you may see diagrams of this in the future. So as I mentioned, it's important to note this particular pattern because that will be on exams as well. And usually it doesn't affect the face, scalp, palms, or soles. And that's an important thing to take into account when you see a patient. You want to examine these areas, because if you see involvement in the palms or soles, then you would actually consider a different diagnosis in your differential, because there are other conditions that can look very, very similar to this. And an important one that I didn't include in this presentation, but that would essentially look the same as this, except you can have that palm and sole involvement, is syphilis, which is one that you don't want to miss and you absolutely want to treat. So in terms of treatment, like I said, a lot of people don't even experience any symptoms. So it's mostly supportive. You want to follow a sensitive skincare regimen. If your patient is having some discomfort from itching, you would prescribe a topical steroid. In some cases, acyclovir, which is an antiviral medication, can be used to shorten the course of the condition. But again, this is not anything that's serious or going to cause any problems, even if you let it run its course. And then, as always, whenever you have inflammation on your skin, any discoloration may take time to resolve. Do you guys have any questions?
There are definitely tons of questions going on right now. We can answer a couple.
Okay.
Someone asked, are these fungal and viral infections infectious? Like how infectious are they? Or, you know, what's the prevalence of it? What would we expect from them?
So no, so Tinea versicolor, you know, that's caused by malassezia is really caused by the overgrowth on your own skin. So if you just touch a patient with it, or, you know, if you know somebody that has it and you touch it, you're not just going to get it. It doesn't work that way. It's not like something contagious that way. And Pityriasis rosea is actually through gets transmitted through droplets, so or reactivation of the virus. So it happens a lot during certain months like spring, but you won't get it from somebody that has the rash.
Great, thank you. Also, there's some questions asking about, a lot of questions actually asking about acne and just how often you see it, how complex is it, and what kind of products would you, recommend to treat it?
Yeah. So, I mean, we see acne all the time, every day, all day long. Like that's bread and butter for dermatology, so we see it all the time. Treatment really varies because there are different forms of acne. So you have comedonal acne that's just like bumps. You can have blackheads or whiteheads, but those are your comedones. You can have blackheads are open comedones, whiteheads are closed comedones. So we treat that type of acne differently than what we would treat a cystic acne. There's also an inflammatory form of acne, hormonal acne. So treatment can be a little bit complex, even though acne seems like it would be something very simple to treat. And it is for us because we see it so much and we know all the different medications that we can prescribe for it. Sometimes it's a little bit more complex than that, because there are different things that you want to use to treat the different forms. So there's not like, I can't just give you a blanket type of treatment regimen and say, do this and that, because everyone has a different form of acne. And then even individually, even if I take like 3 people with the same form of acne, they may not respond to the medications the same way. But in general, over-the-counter products that are available are benzoyl peroxide, salicylic acid. Retinoids are great for treating acne, and they're a staple, and pretty much anyone that has acne would be on a retinoid unless there's a reason for them not to be. And in terms of over-the-counter, Differin gel is one of the only like prescription strength. It was previously a prescription medication, so it's one of the only prescription strengths retinoids out there.
Thank you so much. We had a few questions about Eczema. What are some general treatments? Is it steroid based? And also some questions about rosacea as well. And the same, how prevalent is it? Is there any treatments that you can do?
Yeah, so for, eczema, it's very common, and we see it a lot in children actually, and a lot of times people grow out of it, but sometimes they don't, and we can see it in adults as well. The problem with eczema is the skin barrier function of the skin. So our skin is made to protect us from the outside environment. And when you have eczema, there's a problem with that function of the skin, and the barrier, it's not functioning as a barrier the way that it should be. So then things that you get exposed to from your environment can cause inflammation and cause this whole cascade of inflammatory cells, and which ultimately leads to the rash and all that inflammation that you see with eczema. So the key actually is to try your best to repair that skin barrier and protect your skin. So one of the most important things to do is to follow a sensitive skincare regimen. So you want to avoid really hot showers. You want to keep your showers short and immediately moisturize after a shower. And you want to do it with something that's fragrance free and something that's nice and thick. So usually something like CeraVe cream or even Vaseline or Aquaphor work well. So that's going to help create that barrier between your skin and the environment. So that's one of the most important things. And overall, you want to try to avoid things that could potentially irritate your skin. So we do tell our eczema patients to avoid products that have fragrance in them. And then of course, you know, if you have an active rash, then we want to treat it. And a lot of times we do use topical steroids to use it. In severe cases, we do have other medications like biologics, like Dupixent, that can be used to kind of halt the process of inflammation and help with the condition. But that's not something that we use all the time. It's usually in severe cases. So most of the time we're going to go over a skincare regimen with you and make sure you understand what a sensitive skincare regimen is, and make sure that you're moisturizing as much as possible, or twice a day at least. And then we try either steroid creams for active areas and sometimes non-steroidals as well, depending on the area that we're treating.
Great, thank you so much.
And then for rosacea, it can be a little bit tricky. It's important to know that there are certain triggers. So extreme temperatures, either extreme heat or cold, even with your beverages or anything that you eat, extreme temperatures can be a trigger. Spicy foods, alcohol, those are all triggers to rosacea that can cause a flare. There are different forms of rosacea as well. So you can have a type where you have just blood vessels and flushing of your skin. So that just looks like pink patches. You can have a type where you have acne-like bumps. So that's the inflammatory type of rosacea. And then you can have a type that causes deformation of certain parts of the face. So like we call it rhinophyma, when the nose gets large and distorted, and that's a different severe type of rosacea. So treatment depends on the form. We usually discuss avoiding any triggers as the ones that I mentioned. Lasers really help with the forms that cause the pink patches on the skin. So that's really my go-to treatment for patients that have that telangiectatic type of rosacea. We want to treat with lasers. We do have topicals that we can give for that, but a lot of times they don't work, or there's a rebound redness that occurs. So really the most beneficial treatment for that type of rosacea is laser treatment. And then for the inflammatory type, we typically prescribe an antibiotic, a low dose antibiotic like doxycycline that has more anti-inflammatory properties at a low dose. And we do that along with some topical creams.
Great, thank you so much for that. I know a lot of people were asking questions about it. A lot of people wanted to know about, you know, what your typical day-to-day looks like, and what kind of, if you're working in a private practice or a hospital setting, and what's more common for dermatologists?
Yeah, so for dermatologists, I feel like private practice is more common. Usually, you know, it's going to be that versus an academic center. And at an academic center, then everything's a little bit different because you're working with residents. You have your clinics and stuff, but a lot of times you're teaching residents, so you have a lot of other types of responsibilities, and you likely would have call at the hospital as well in case you're needed for certain cases. So that's a little bit different. I'm at a private practice right now. Prior to COVID, I was at a private practice working full time. So my day to day, I was working 4 days a week actually, and I was seeing all sorts of cases, a lot of general dermatology, lots of full body skin exams where I'm screening for skin cancer, and then some surgery, cutting out skin cancers or cysts, and then a little bit of cosmetics mixed in as well. That was prior to COVID. After this all happened, things kind of changed in my household because my kids, my 6-year-old daughter, she couldn't just go to school anymore. I had to homeschool her. So I made a change actually, and I'm currently at a different private practice in Corona Del Mar here in California. And I'm only working 2 days a week right now, and I'm waiting to start another 2 days at the VA, where I'll be working with residents teaching surgery. But for now, I'm at a private practice where I'm doing cosmetic dermatology.
That's great. Thank you so much for that answer. And we also understand the COVID struggle, so we get it. Do you work with people who have skin allergies, and what are some common skin allergies you've seen?
Yeah, so we see allergic reactions a lot of times. It's really hard to pinpoint the allergy many times, but a lot of times we will have patients that come in with hives, and we call that urticaria. And if we can find the cause, it's great. But unfortunately, a lot of times we end up calling it idiopathic urticaria or chronic urticaria, and we really can't pinpoint what's causing it. Sometimes it just has to do with like the immune system itself acting funny for some time, and then it suddenly resolves, which is kind of odd, but I've seen that happen a lot. A lot of times we have to work closely with allergists because we frequently will make the diagnosis, and then we can do like patch testing to see if there are any ingredients that you are sensitive to. So when we do a patch test, there are different forms, and the most, like, there's some basic ones where you could check like 40 different ingredients that are commonly found in different skincare products or household items. And what we do is we apply the patch to your back, and then you can't even wash it for a couple of days, and we remove it. And after 48 hours, we remove it and we take a look. And if we see like signs of an allergy or raised hives or a red, itchy, scaly spot, then we know that you're reacting to that particular ingredient. So ours are kind of limited. So a lot of times we send out to an allergist as well to do more testing, but unfortunately they come up empty-handed a lot. Types of allergies that I've seen. Well, I've seen people have sensitivities to different things. Sometimes it can even be like an irritant dermatitis to something and not necessarily like hives, but I've seen people have skin reactions to different like cosmetic products that they've been trying to use, like, and it turns out that they're just sensitive to them. So it could be things with fragrance or natural oils, a lot of things that seem that would be okay and safe. Actually, you'd be surprised they're not necessarily that, great for some people. It doesn't mean that it's bad for everyone. And unfortunately, a lot of people think that like, oh, fragrance is bad for everyone and you can't absolutely not have it. It's actually okay if your skin is not sensitive to it. And it's the same way with like essential oils. Some people can be sensitive to them. And even though you think something is natural, you may have a sensitivity to it. So yeah, I've seen people basically have sensitivities to things that are in their products. And I usually just have them stop everything and keep everything as bland as possible. I've also seen someone just have hives like due to stress. And then as soon as that stressor is removed, the hives disappear, which is really crazy that it can happen, but it really does.
Great, thank you so much. I know a lot of people were really interested in that. There's tons of people asking about what kind of subspecialties or fellowships, could you do with dermatology, and a little bit about the difference between just general dermatology and dermopathology.
Yeah, so, when you do dermatology, you have to go to medical school. So you do that for 4 years, and then you're going to do your residency. And for residency, you have to do an intern year. So 1 year, you get to choose what you want to do. You can do internal medicine, pediatrics, a year of surgery, whatever you want pretty much. And then you have to follow that with 3 years of dermatology. So that's your dermatology residency. So residency is actually 4 years, but it includes that 1 year of doing something else. So after you complete your dermatology residency, you can do a fellowship, and there are different ones available. You could do a fellowship in dermatopathology, which is when you're looking at pathology slides from skin. So that's, whenever anyone does a biopsy, you place it on, sorry, I'm just going to X this out. You place it on a slide, and then you have to have someone look at it. Now, when you do your residency, like, we have to all learn about dermatopathology, and we learn about the different features that you see in different conditions, but you can do an extra year of fellowship. And actually most of the dermatology fellowships are just another year, specializing to do that only and go into more depth on that topic. So dermatopathology is one of them. You could do a fellowship in pediatric dermatology, where you focus more on seeing patients, kids. So when you do your residency in dermatology, you're going to see patients of all ages, but you can do that fellowship after to focus more on children. You could do a cosmetic and laser fellowship. So that's more for doing laser procedures and cosmetic procedures like fillers and Botox. You could do a Mohs fellowship. So that's a very special technique that we use to cut skin cancers, typically in areas where we want to spare tissue. So like the face, the hands, genital area. So that's another type of fellowship that you can do. So lots of options, and those fellowships are usually a year, an additional year post residency. You don't have to do a fellowship, because you do end up seeing or having experience in all of these different settings in your residency period. Like we all get exposure to cosmetics, we all do Mohs rotation, we all do we see kids and stuff, but it does go into more detail. So post residency, if you didn't do a Mohs fellowship, some people did enough during their residency that they may feel comfortable just going out and practicing and doing the Mohs, but a lot of us don't unless we did the fellowship.
Great, thank you so much. There were some questions earlier, just asking a lot more about cosmetic and aesthetic dermatology, and whether you would focus more on that in your practice, or more medical, or is it kind of 50-50?
So you get to choose, that's the great thing about dermatology, is that you get to choose what you want to focus on, and it's totally up to you, depending on the job that you decide to take, or even if you have your own practice, you really get to run that and decide what you want to do. So for example, right now, the private practice that I'm at, I decided that I wanted to do cosmetics there. And actually that's only a cosmetic practice. So that's what I'm currently doing. So Botox, fillers, lasers, tightening devices. So purely cosmetics. Typically though, like if you just go to a private practice that has everything, so like the one that I was at before this whole COVID situation happened. I would say I was doing more like 70% general dermatology. So seeing acne, different types of dermatitis or rashes, lots of skin checks, as I mentioned, rosacea, that sort of stuff. And then I probably did like 5% cosmetics, so very, very little cosmetics there. And then the rest of it was surgical dermatology. So there's always a mix, and it just depends on what you want to do and what you like. And I think that's what's good about dermatology, that it is procedural based too, you know, and you have options. So you get to do whatever it is that you enjoy.
Great. Kind of going off one of the last things that you said, a lot of people were asking about, you know, what are the most common procedures that you'll do, and then what would be considered the surgical procedures versus just, you know, the in practice.
Yeah. So for me right now, because I'm doing a lot of cosmetics, the common procedures that I do are laser treatments. So like non-ablative laser treatments like Fraxel and Clear and Brilliant that actually help stimulate collagen production, help with skin discoloration, treat fine lines and wrinkles. So more like superficial based type of lasers. And then I do a lot of Botox recently. So that's used to treat fine lines and wrinkles as well. In terms of surgical dermatology, a lot of it has to do with treating skin cancers. So after you do a skin exam, if you find something that looks suspicious, you would do a biopsy. That's basically sampling the concerning lesion. And then that goes to pathology, and you would get your pathology report back. If that's a skin cancer, then you would bring your patient back for surgery on that area. So most of the times, you know, I'll talk about like the most common form of skin cancer, which is a basal cell carcinoma. You would find the spot that you had biopsied and then take a 4mm margin around that and cut it out and suture it, put it back together. So that's like very common in terms of surgical dermatology. That's what you're doing, cutting out a lot of skin cancers, but sometimes cysts as well. So those are the most common types of surgeries that we do. And then if you're a Mohs surgeon, you're going to be cutting out those skin cancers, but in those other areas that I had mentioned before, like the face, the hands, the feet.
Awesome, thank you. Someone was asking about if you treat burn survivors, or is that a little bit more plastics?
No, so it really depends. You know, there are dermatologists that have focus on that. I think that depends on what research you've done and if that's been a focus or interest that you've had. So as a dermatologist, you can do that. I personally haven't treated many, but there are even certain residencies that have like that work closely with like burn units and stuff. So those residents that have trained at those particular facilities have a lot of experience with that. So even within your residency program, you know, it can be heavily geared towards a certain area. For example, my residency had a lot of great surgical experience. So some residencies won't have as much surgery available. So even within different residencies, you'll have more of something just depending on who your attendings are, your patient population, you know, that sort of stuff. So it does vary per residency, but overall we all learn the same stuff and we all take the same board exam. But your residency can be heavy on a certain area and you may feel more comfortable with that. So for example, mine was surgical heavy and I feel very, very comfortable performing surgeries.
That's so cool. Thank you for sharing that with us. Natalie asked, do you work closely with pathologists within your previous private practice to perform diagnostic tests, or do you usually do those stuff in-house?
So where I worked before, we were lucky that we had a dermatopathologist in our clinic and we had our own lab. So that actually was super, super helpful. Not only the fact that we had our own lab, but the fact that we had a dermatopathologist, because if you just have a pathologist looking at your slides, of course, they'll give you back the report and answers, but when you have a dermatopathologist, you have someone that actually knows the clinical presentation, knows everything that you know in terms of dermatology, but plus they're an expert at looking at the slides, and they know exactly what they're looking at, so they can really help you, like even if you are not on point with the differential that you gave in terms of the diagnosis, they can really help guide that. By a lot of times we take photos when we do a biopsy so that the dermatopathologist can go back to the chart, look at the photos, and then they can make a clinical correlation with what they're seeing under the microscope. So that's really helpful. And at the clinic that I worked at before, I did work closely with our dermatopathologist, because if I had any difficult cases, I always made sure to tell her, like, hey, I took some pictures for you to look at because I need help trying to figure this out. So that's good that they're able to correlate the pathology with the clinical presentation.
Yeah, that's super interesting. That's great. We had a couple people ask about, what's the most satisfying part of your job and what motivates you to go to work every day?
Yeah, so I really love what I do. I think I'm very lucky. I love dermatology for a lot of different reasons, but there are so many good things that you can make out of it, really. For example, when you find melanomas, like you're saving somebody's life, and that's really rewarding and scary at the same time. And sometimes you do worry about your patients depending on what you see or when you found it, or if it's a difficult case, but it is extremely rewarding to know that you make a difference, and that you can save somebody's life just by examining their skin. So that's one thing. I think a lot of times too, the skin, that's the outer surface of what people see, and that can have a great psychological impact for all sorts of patients depending on their skin condition. So I find that to be rewarding too, in a sense, because whenever I've had patients that have come really distraught because of something that's on their skin, or a certain condition that they have, whenever I can help them and I see that improvement that they have in their mental status, then that's really rewarding as well. In general, though, like dermatology, I think it's a great specialty because you do have variety. You can do different things, which I find really interesting and fun, because when you're doing something every single day, it can get kind of mundane. And the fact that you can do different things in dermatology helps with that. So if you want to do more surgery and you really enjoy that, you can do that. If you want to do cosmetics, you can do that. So I like the variety that dermatology offers. And we also have a great schedule. So like we really can have that life-work balance, and that makes a huge difference.
Yeah, that's great. It's probably why it's one of the most competitive, as you can imagine. So that's completely fair. Someone asked about your thoughts on Accutane for acne.
So I think Accutane is a great medication for those that need it, and it can be life-changing. I've seen amazing transformations in patients that have severe cystic acne, and so that's the most common indication for that medication. And of course, as with all medications, you can have potential side effects, but I think if your physician manages it well, and with that medication, you actually need to have regular visits and close contact with your doctor. But yeah, it's a great tool to have and use for patients with severe acne.
Yeah, a lot of people are saying that they've seen, just completely different effects for them versus their friends. So I know it's a very debated topic.
It is, especially on social media.
Yeah, we love social media and hate it at the same time. Someone was asking about your input on nickel allergies and what are the causes and how to treat it.
Yeah, so in terms of causes, it is what it is. It's a nickel allergy. So anything that contains nickel can actually cause a flare. And what it does is it causes a dermatitis. So easier to show, but a common presentation that we usually see on exams is somebody wearing like jeans and they have their button, buttoning their jeans, and right by their belly button they have a little red ring, scaly and itchy ring, and that's usually what we see on exams for a nickel allergy. But that's what it is, exactly that. It's an allergy to nickel, and so you have to be cautious or careful with anything that contains nickel. The patch test that we use can test for a nickel allergy. So that's one thing that we check for sometimes if we suspect that. So things that you would have to be careful with, there's sometimes your clothing, like buttons that might have clips or buttons that might have nickel, sometimes like jewelry, like watches or bracelets that might contain nickel. And so the treatment, if the best thing to do is avoid the nickel. If you can avoid it, then you'll never get the dermatitis really from the nickel allergy. If you do happen to have exposure and you develop the rash, then a lot of times what we do is prescribe a topical steroid to help calm that inflammation down and clear it. But the main treatment is avoidance of the nickel.
Good to know. Thank you so much. I think we'll take two more questions. One is very popular, and just your opinion versus on the MD versus DO route for dermatology and how often you see DOs.
Yeah, so honestly, I didn't know that many before I was on social media, just because I took the MD route and everyone in my residency was an MD. But on social media, I've met a few, and I think they're great. And honestly, like, I think that there's added value to being a DO, because you're learning like even another aspect, another side of medicine ultimately. And so I think that there's value to that. I don't have much to say. I don't know very much about it because I'm an MD and I don't know that many DOs, but so I'm not sure in terms of residencies, like if there's a certain percentage that they take or what it's like. But I do know, I'm trying to think of somebody, if you guys need more information on that, I do know someone on social media that's a dermatologist, a DO. So if you want their contact, I can provide you with that.
Yeah, absolutely. You can just DM us and we'll give that information out to whoever wanted it. And I guess we'll end on this last question is, as we're finishing up this pandemic, hopefully, and finishing up our pre-med journeys, is there any advice you have for us going forward?
Yeah, that's good. Try your best to stay focused. Don't give up. It's kind of like ups and downs with medicine. It's a lot of work, but if you try your best to stay focused and just keep going, it's totally doable. Try not to stress. I know that sounds crazy. Especially like even coming from me, like I feel like as an undergrad, pre-med, and even in med school, I was constantly like stressed out about performing well so that I can make it to the next step, like I constantly had something that I was working towards, and I wish I would have not stressed out as much. At the end of the day, your health is really important, and you want to make sure that you have a good balance of everything. And I think as long as you work hard and you stay focused, then things really work out. So just hang in there. I know, especially right now with the whole situation with the pandemic, it's kind of hard to be able to do the same things that we had available before this, and things are a little bit crazy, but this too shall pass, as everyone says, you know, and we'll eventually have some sort of solution or vaccine and things will get better. But just hang in there and stay focused. I think that's the best thing you can do is stay focused. And if medicine is something that you really want, then that really will help you. And it takes a lot of discipline, but if you do that, you'll get through it. And in the end, you'll end up doing whatever it is that you love to do.
Yeah, I think that's great. And everyone is just saying thank you in the chat if you open it up. There's so much praise and they appreciate all the information that you give.
Oh, you're welcome. I wish I could open it up, but I'm so bad with this.
It's okay. It's okay. I'll let you know. Everyone's just saying thank you and thank you and thank you.
Oh, yeah.
All over it again.
Now. I opened it. Yeah. Oh, you're welcome, guys. My pleasure. I hope you guys enjoyed the presentation. I tried to keep it short. But yeah, I just wanted to, you know, show you guys a little bit of dermatology. So I hope you guys enjoyed it.
Yes, thank you so much for being here. We appreciate you giving us time, especially on your Saturday morning. And we hope you have a great day.
Of course. Thank you so much. You guys have a great day too and a good weekend.
You too. Thank you so much.